Welcome everyone to the ICIS Free September webinar. And myself and my colleague, Dr. Davide Farida, will be talking about head and neck cancer imaging, pushing beyond morphology. We'd like to acknowledge our sponsors, which are Siemens and Gerbe, and would encourage you to be following this on social media and to follow us on Twitter as well. A couple of other advertisements. The 22nd International Cancer Imaging Society meeting is next year, 25th to 27th of September. And we'd welcome you to also attend the November webinar entitled Guidelines for Trustworthy Artificial Intelligence in Medical Imaging. And moreover, I would very much like to encourage your attendance at the Masterclass in Imaging of Head and Neck Cancer, which will be a classroom course held in London next February, 9th of February, early next year, where myself and Davide will be in attendance, also Professor Anne King, and led by Professor Robert Hermans. So I'm first going to talk on diffusion imaging in head and neck cancer for the next 25 minutes. I'm based in London at King's College Hospital and Guy's and St Thomas's Hospital. Just by way of background, I'm going to be talking about mucosal carcinomas of the oral cavity, larynx and pharynx, which represents collectively head and neck squamous cell carcinoma, and 90% of cancers in the head and neck overall. The sixth commonest cancer, comprising 4% of cancer patients overall. The presentation at a late stage is unfortunately frequent, and whereas early grade 1 and grade 2 tumors can often be successfully treated with single modality treatments, despite multimodality treatment, those with stage 3 and stage 4 cancers have a 30% treatment failure. There's an array of different cross-sectional imaging techniques which are used to complement the clinical and endoscopic examination. The endoscopic examination is excellent for the mucosal surfaces and for palpable lymph nodes, but imaging is used to detect occult and submucosal disease. And in this respect, it's able to help diagnose squamous cell carcinoma of the upper airway digestive tract, to consequently stage and provide accurate delineation for radiotherapy planning. It's able to monitor treatment effects in the early period, and maybe treatment can therefore be adapted in the early treatment. And it's also able to help detect cancer recurrence in addition to post-treatment changes at a later stage when there's clinical evidence of potential recurrence. So diffusion-weighted imaging is a complementary sequence that can be used with our MRI protocols. It is now a regular sequence performed at both 1.5T and 3T, and whereas it's rather lagged behind neuroimaging applications due to the anatomical constraints of the head and neck, there's now ways of mitigating this, and it can be successfully performed in the setting of head and neck cancer. So what I'd like to do is outline some of the challenges, the technical challenges, and how we evaluate diffusion-weighted imaging in the head and neck. And the bulk of the talk will be about how we assess qualitatively and quantitatively diffusion-weighted imaging and try and determine what its role is. So it's well established, the basis for diffusion imaging in MRI. It's dependent on the Brownian motion of fluid, which randomly passes between the intracellular and extracellular spaces. But of course, this is not free due to cellular membranes and molecular barriers. And we're assessing with our diffusion-weighted imaging a combination of the extracellular, intracellular, and microvascular diffusion. So briefly, how do we measure it? Well, we have diffusion-weighted sensitizing gradients, which are performed either side of the refocusing pulse. The first gradient will dephase spins, and then an equal opposite gradient will rephase these spins. Now, one of two things can happen. Either if the spins do not move, they'll be fully refocused and fully rephased, in which case we will return a high signal. However, if there is movement of these spins, then there will be reduced signal because they will remain dephasing, and the reduction in signal is going to be proportional to the movement along the diffusion gradient. So really, we're trying to, as a result of demonstrating increased DWI signal, cellular tumor, and basically interrogating what the cytoarchitecture is. And it therefore aids the demonstration of squamous cell carcinoma within the head and neck as high signal. But there's a number of other substrates which will result in increased DWI signal within the head and neck, for instance, inflammatory cells, fibrosis, and proteinaceous fluid. And this then contrasts with other substrates that result in free diffusion or low signal on DWI, such as necrosis, edema, and microvascular perfusion. In order to gain the most amount of information that we can from our diffusion-weighted imaging, we need to take one step further, and that is to acquire diffusion-weighted images with a series of different B-values. The B-value can be altered by increasing the magnitude of the diffusion gradient, increasing the gap between them, and increasing their length. And this enables two things. First of all, by plotting out these various calculations of the signal intensity on diffusion-weighted imaging, we can estimate the apparent diffusion coefficients. This gives us a quantification of our values. It also removes the effect of the T2 weighting to the diffusion-weighted imaging. The diffusion-weighted imaging is innately T2 weighted sensitive because it requires a long TR in order to gain enough signal, and it also requires a long TE in order to incorporate this diffusion gradient after the refocusing pulse. So we will routinely create diffusion-weighted imaging depiction at high B values, and we will compare those with the map created from the ADC. Therefore, with cellular tumor, we will demonstrate increased DWI signal and restricted diffusion showing low ADC signal, whereas if showing in this parotid tumor, whereas in a sebaceous cyst where there's increased fluid movement, we will show that there's low signal on the DWI sequence, whereas there's free diffusion or increased signal on the ADC map. So for routine clinical applications, we would usually use B values in the region of 50 to 100, and we would use high B values in the region of 800 to 1,000. And we will calculate the ADC with this mono-exponential model. We try and avoid the B values in this very, very low range due to its contribution of fast diffusion, which is really demonstrating the microvascular perfusion. And we want to separate the contribution of that from our cellular diffusion, which is calculated in this range. For research applications, we might have more interest in B values at the far ends of this scale. And in this situation, we often apply multiple B values and multi-exponential volumes. In particular, in the head and neck, IVIM, which interrogates these multiple low B values, gives us an indication of the pseudo diffusion, or the microvascular perfusivity, and at least 4 B values below 200 would usually be required in order to apply these techniques. Similarly, at the upper end, we can get an estimate of the intracellular diffusion by looking at very high B values. There's been some studies looking at these B values of greater than 2,000, and also because of the sort of non-Gaussian distribution of diffusion at these high B values, we can do kurtosis imaging as well. So what are the challenges in terms of imaging, diffusion-weighted imaging in the head and neck? Well, first of all, it's very heterogeneous tissue, contains fat, water, air, bone, very closely opposed. It's generally a low acquired signal, has a variable geometric shape, so challenges for shimming, and susceptibility artifacts, particularly surgical implants, dental restorations, and all these very sharp air tissue boundaries, which may result in susceptibility effects. Then there may be bulk movement. These patients are often unwell, and even if we perform short sequences, there may be coughing and breathing that resulting in image degradation. So in order to overcome this, we usually perform sequences with single shot spin echo EPI. This, within a reasonable time frame, will obtain images with a high enough SNR. We would usually use the B values I mentioned, but often also apply a B value of 0, because this allows quite a nice correlation with the structural images, and also requires, also results in an image that we can perform regions of interest and translate them directly to the high B value and ADC images. But there are still problems. We have limited spatial resolution and blurring. We're at these air tissue interfaces, and also where there's implants and susceptibility effects, there may be resulting in distortion. And along the phase encoding axis, we will also get ghosting, particularly if there's poor fat suppression. There's some ways of mitigating this. Sequences such as resolve, acquiring the case space in different ways may be used. This is a multi-shot technique, and we can also acquire fast spin echo multi-shot techniques such as propeller in order to try and overcome some of these problems. But they're generally longer sequences. So what simple methods can we use to improve the depiction and diffusion-weighted imaging? Well, we can reduce susceptibility artifact by good shimming and putting in saturation bands. We can use multiple shim blocks, try and avoid them, placing them over areas of air. We can use a posterior saturation band to exclude the fat at the back of the neck. And we can perform small field of view imaging using parallel transmit techniques, for instance, zoom it on the Siemens scanner. Other tips: effective fat saturation to remove the lipid effects and reduce ghosting, and also acquiring phase encoding in an anteroposterior direction, reducing the effects of pulsation and ghosting. So what about our two main approaches, which is qualitative analysis and quantitative analysis of diffusion-weighted imaging? And I want to go through them, which is essentially a visual assessment with qualitative analysis and a calculation of the ADC with quantitative analysis. I'll try and provide some tips with qualitative analysis, and we'll also go through a little bit of the literature with quantitative analysis. So what about just looking at our diffusion-weighted imaging? What can we benefit? How can we benefit from this? Well, first of all, when we see squamous cell carcinomas, they often merge with the adjacent soft tissues, with the adjacent edema, and potential treatment effects. And diffusion-weighted imaging is successful in terms of removing those effects and better depicting the extent of cellular tumor. If, for instance, this soft pellet tumor, it's merging with the adjacent normal soft tissues. When we do a diffusion-weighted sequence, we can see it's much better demarcating, so improving our staging and improving our delineation for radiotherapy planning. However, you can see there's very, very poor background signal elsewhere within the image, so we always need to correlate with structural sequences. The delineation of tumors becomes a problem often when we have peritumoral edema. For instance, this left-sided hemi-tongue tumor, diffuse enhancement, but we can see both with our PET metabolic imaging and our ADC map that only a proportion of that is actually representing cellular tumor. It appears that the anterior enhancement actually corresponds to free diffusion and hence due to peritumoral edema. This can similarly apply when we're looking at invasion of tumor into both the mandible, other bony structures, and also the cartilages within the larynx. Here at these sites, we often get abnormal signal, for instance, due to periodontal inflammation and peritumoral inflammation. And the diffusion-weighted imaging, it helps us discriminate these particular effects. As I mentioned before, it's becoming increasingly applied MRI in terms of radiotherapy planning, and often the structural images may have an ill-defined border with respect to the adjacent tissues and the peritumoral inflammation, whereas diffusion-weighted imaging can better delineate this. The one problem we have with this is that, particularly using EPI, there will be distortion of the tumor, and so we need to always correlate it with the structural imaging. There may, in principle, be some benefit of using non-EPI sequences, particularly when there's susceptibility effects of the radiotherapy shell. And you can see how this non-EPI image slightly better depicts the structure of the oropharyngeal tumor in this situation. But you'll also notice that there's very poor signal to noise, which precludes its routine application. I mentioned high B values before, and sometimes it's useful and interesting to look at the high B value diffusion-weighted image. Here we've got one performed at 1500 rather than 800. And you can see, although that the overall image is going to be of reduced signal as a result of the high B value, it sometimes better discriminates from the normal structures, such as the normal lymph node and salivary gland tissue in this situation when we've got very, very cellular tumor. I mentioned about the post-treatment setting and how useful it is. And we've really lost many of our markers of defining pathology in this situation because we've got so much disturbance of the adjacent tissues and adjacent tissue planes. I often show this to some of my trainees and ask them to tell me which side of the tongue that the base of tongue, this recurrent tumor is affecting, and knowing full well that I wouldn't be able to do it. But you can see that on diffusion-weighted imaging and on PET-CT, it's located to the left side of the base of tongue. And it's been shown in this paper how qualitative assessment of DWI is complementary to PET-CT in this regard. Here's another example of a patient following radionecrosis for treatment of a laryngeal tumor. And you can see how there's diffuse signal abnormality, endolaryngeal and perilaryngeal signal changes and changes within the cartilage itself. Very difficult to discriminate treatment effects from the tumor, but you can see with diffusion-weighted imaging, and this correlated with the findings at laryngectomy, you can see whether the cellular tumor is. I also mentioned the effect of T2 shine through on a diffusion-weighted sequence, and we must always correlate with our ADC maps in this respect. So here we've got a benign lesion, a plunging ranula within the right submandibular space, but very bright on the DWI signal. And it's only when we correlate with the ADC map that we realize this corresponds to free diffusion. So that's one pitfall. The same applies as a result of T2 blackout. So you can have T2 effects due to low T2 signal. So here we've got a lymphoma, an orbital lymphoma involving the left medial canthus. And you can see that on diffusion-weighted imaging, the effects of this low T2 signal are to result in intermediate diffusivity, the diffusion-weighted imaging signal. However, it is shown to be of high ADC value on the ADC map. Another catch can be when we're trying to image cystic or necrotic lymph nodes, particularly in the HPV situation. And that's because the necrosis will be demonstrated free diffusion. So it becomes slightly less conspicuous on our diffusion-weighted imaging, again, accentuating the need to always correlate with anatomical images. It's useful to be aware of what normal structures will be a bright signal on diffusion-weighted imaging. Lymph nodes, obviously, even normal lymph nodes will bright DWI signal, and they're often quite a useful way of actually co-localizing where lymph nodes are present on our other structural sequences, so we can visually cross-reference with them. Similarly, the spinal cord will be bright DWI signal, and salivary gland tissue will be bright DWI signals. We mustn't overinterpret these as pathological findings and match them to the anatomical imaging. And the final pitfall is that benign pathologies can result in increased DWI signal, both an abscess, as in this situation, and also benign pathologies such as sebaceous cysts. And sometimes the DWI signal can be really very, very increased, and often mimic tumors that show markedly restricted diffusion, such as lymphoma. So let's move on to the quantitative analysis now. And I'd like to both talk about how we acquire these values, and then review the current literature in terms of where it is usually applied. So how do we perform the analysis? Well, it's performed in a number of different ways, which needs to be appreciated when we're trying to interpret the literature. It may be that we perform a number of small regions of interest within the core, or a single region of interest within the core of the tumor where it's brightest. It may be that we perform a region of interest around the periphery, trying to encompass the whole tumor, usually 1 to 2 millimeters in from the periphery of the tumor. Or it may be that we apply this on a number of levels in order to create a volume of interest. We often need some guide from other sequences to try and know where to place our regions of interest, particularly in necrotic lymph nodes, where we want to usually avoid the area of necrosis. One approach would be to use the gadolinium-enhanced imaging, but the problem with that, there's often some degree of distortion on the diffusion imaging. So other authors and approaches would use either a high B value or the B0 map in order to guide the placement of the region of interest. It's quite controversial what the smallest region of interest is that we should be applying on diffusion-weighted imaging, but usually 4 to 5 millimeters is reproducible. You should also appreciate that the values obtained from the lymph nodes in the primary tumor are frequently different, and thus has an impact on what the implications of that is in terms of diagnosis and outcome. Now, what metrics may we use? Well, I've generally referred to ADC mean so far, but we know that there is variation in cellular differentiation and proliferation across the tumor, and some degree of heterogeneity. So in order to capture these particular aspects, some authors have used the ADC min or the ADC max. They've also used histogram analysis and applied heterogeneity analysis. This is verging on Radiomix analysis that you'll be hearing from a subsequent speaker, and a series of different parameters, such as first order parameters, for instance, entropy and skewness, may be applied, or second order parameters as well. And there are studies which have used this both in the pre and post treatment situation. Quite a nice approach, which is increasingly being used by authors, is to create subvolumes or ADC thresholds defining a volume of tumor that is falling below a certain ADC threshold and looking at the implication of that on prognosis. So what are the areas where this has been applied? Well, first of all, for tumor detection and characterization, then as a prognostic application, applying it pre-treatment to see what the response to treatment is going to be, and finally to monitor treatment or to try and detect recurrent tumor in a later phase following treatment. And I'll go through these in turn and we'll look at some of the current literature. So firstly, tumor detection and characterization. Well, obviously the way we normally diagnose malignant tumor is with tissue sampling, but sometimes this may be misrepresentative. It may be, and tissue sampling is not without its morbidity. There's even earlier studies showed that it was possible to distinguish benign from malignant tumors in the head and neck with ADC. However, there are a number of exceptions. For instance, benign paragangliomas can demonstrate restricted diffusion. There's some malignant tumors, such as mucoepidermoid carcinomas, that can show free diffusion. So this is difficult often to apply in reality. This is try to overcome this problem by actually restricting the different histologies we've been trying to distinguish and also apply to particular subsites. But sometimes this is also a problem, for instance, in the nasopharynx, where we might be wanting to distinguish squamous cell carcinoma from lymphoma. Different types of lymphoma result in different restricted diffusion. So for instance, Hodgkin's lymphoma can result in greater free diffusion. And then we also find that undifferentiated carcinoma in the nasopharynx can overlap both squamous cell carcinoma and lymphoma. So in reality, it's often difficult to apply these things to distinguish different tumor types. Lymph nodes is a key point in terms of head and neck cancer staging, and particularly those that are going to be of small size, because this is one of our key ways of trying to distinguish pathological lymph nodes. And a number of studies have shown that there is a potential threshold to distinguish malignant from benign lymph nodes. However, we must have some caution in this regard. First of all, if you look at the studies, the thresholds differ quite markedly, and it's certainly not been a universal finding. Moreover, we already have really quite robust diagnostic pathways in terms of distinguishing malignant lymph nodes, and it's often a difficult process to perform in view of the heterogeneity of lymph nodes. And it's understandable that there may well be sort of quite marked variations even in benign lymph nodes, because areas of lymphoid follicles and stromal fibrosis in reactive lymph nodes can actually result in restricted diffusion. What about other ways of characterizing tumor? Well, again, early studies demonstrated that areas of restricted diffusion, of greater restriction of diffusion, often correlated with more undifferentiated tumors. More recently, it's been correlated with molecular biomarkers such as VEGF and p53 expression, and the degree of heterogeneity of ADC has shown some correlation with this, which may be useful as we sort of move towards personalized interventions, and these cellular receptors may be useful to identify. One key area that's also been looked at is in terms of identifying the HPV status of oropharyngeal cancer. This represents 60 to 70% of oropharyngeal cancers in Western Europe and America. And this has a distinct histology, a distinct prognosis and treatment pathway. So it's an important thing to try and identify. Obviously, this can be detected directly on P16 histochemistry by biopsy, but it may give us advanced warning of that from our imaging. Let's have a look at risk stratification and prognostication now. There's a huge amount of data on this, more than 25 studies, and what they've generally correlated is the pre-treatment mean ADC with subsequent response to chemoradiotherapy in those tumors that are treated in such a way. This has management implications. For instance, it may require modification of treatment if we suspect that there's going to be a poor response, and may require more active surveillance. And it's generally been shown, although certainly not universally, that a higher baseline ADC has resulted with a poorer outcome. And this may be due to different histopathological makeups, such as a lower tumor cell turnover, higher stromal content, lower inflammatory infiltrate, and micronecrosis in these tumors with a higher ADC value. which may consequently make them less responsive to treatment. However, again, thresholds do vary widely, and it's difficult to apply for our clinical use. And in particular, there's been a series of recent studies which show that HPV oropharyngeal carcinoma may be a particular confounding factor in these studies. The prognostically good HPV OPC is associated, as we've seen, with lower ADC values, and it may be that this is impacting on the study outcomes here. And in fact, it's due to the HPV status rather than the ADC itself. So this certainly needs to be an important covariate in future studies looking at this. So finally, on to therapy monitoring, and there's two real approaches to this. First is how we're going to detect early persistent tumor, unresponsive tumor to treatment. And secondly, how are we going to evaluate suspicious recurrent tumor at a later stage, for instance, if there's a recurrent mass. In terms of early treatment monitoring, this again has management implications. It may be that we can perform adaptive radiotherapy intra-treatment. It may be that we can intervene, detect persistent tumor post-treatment by early salvage surgery at a stage where it's often difficult to detect with PEP due to the false positives from inflammatory changes with treatment. So the general philosophy with this is that with successful treatment, there's disturbance of the microstructure such that we have increased necrosis and decreased tumor cells, therefore resulting in an increased ADC or a further increase in ADC from the pre-treatment values. And an increase in the ADC will signify improved local regional control, whereas a fall in ADC will potentially result in a poor outcome. And we've got thresholds and absolute values for this, demonstrating a greater than 25% increase, resulting and correlating with treatment success, and also some absolute values as well. This nice graph that was put together by Professor King actually shows how we would expect a residual recurrent tumor to progress with time. So we can see that those that are unresponsive will have higher ADC values at baseline, but as we go through with treatment, it will show in the early phase that the ADC is going up less than the responsive tumor. And as we go through to the later post-treatment phase, that will increase the discrepancy in terms of ADC values between those with a good outcome, showing a continued increase in ADC, and those with a poorer outcome. Finally, differentiating post-treatment change. And here we have again been given thresholds to potentially distinguish post-treatment effects and fibrosis from those due to recurrent tumor. This is absolutely key in this situation that we correlate with the structural imaging for several reasons. First of all, there may be other mimics, benign mimics of recurrent tumor, such as abscess formation, which may result in restricted diffusion. But probably the most frequent problem is when we get an exuberant fibrotic response to treatment, which signifies successful treatment when we see these sort of stellate low T2 signal scars. However, fibrosis itself may correlate with restricted diffusion and decreased ADC. So we mustn't misinterpret this. And the only way we won't misinterpret it is by correlating with our structural imaging. Here's an example. Here we've got a nasopharyngeal carcinoma infiltrating the central skull base and the prevertebral muscles. 6 months post-chemoradiotherapy, we've got this area of residual signal. It's intermediate signal. It's more than 1 centimeter in size. It's not that low signal stellates, low T2 signal stellate scar. It's also showing restricted diffusion and some metabolic activity. Despite multiple biopsies, it wasn't possible to prove there was any tumor there, and you can see how that progressed on follow-up. There are problems in terms of using thresholds that I've alluded to, and this is due to the heterogeneity in terms of the approaches. So it may be that different field strength and coil design will influence the ADC, sequence parameters and the choice of B values, the ways in which the various ways which are outlined in terms of the ROI methodology, and obviously if these are applied to different case mixes with different endpoints, this will also influence the relevant thresholds. So there has been concerns in terms of applying these clinically and in terms of reproducibility. One way of potentially overcoming some of the heterogeneity, particularly in terms of the acquisition parameters, is by using this normalized ADC, which is proposed, and that's by comparing the ADC value with the ADC value within areas that don't alter very much, such as the medulla or the spinal cord, and creating an internal ratio. And finally, how can this be applied together with other parameters and metrics that we may obtain from our other imaging? And it's been shown to potentially provide complementary information, both with diffusion, with perfusion MRI imaging, with DCE MRI, and also with SUV from PET-CT, both performed pre and post-treatment. So to summarize, I think the key points here are that DWI is a routine clinical sequence now in head and neck imaging, but we do need to work on optimizing our technique in order to obtain good quality imaging and accurate quantification. Qualitative DWI is incredibly useful in defining cellular tumors, particularly in the recurrent tumor situation, due to the difficulties with distortion of the tissue planes and making it difficult to evaluate structural sequences in this situation. And finally, in terms of quantitative DWI, this has had slow adoption due to reproducibility concerns, but it looks like the most useful situation and where it's going to have greatest impact will be in monitoring the response to chemoradiotherapy. And thank you very much for your attention. And I will now stop sharing the screen, and I'd like to introduce my colleague, Davide, Farida, who will take us forward on the next talk. Thank you very much, Davide.
Thank you very much. Just 1 second to get my presentation. Okay, thank you very much, Steve, for the introduction. So the topic of my presentation is head and neck radiomics. Are we ready? I want to make 2 preliminary statements. The first one is that my presentation will be much more theoretical and less practical than the good one you had from Steve a few minutes ago. And why this? Because DWI is a routine in our work. Radiomics is coming, could be a routine in the near future, but it's far from being clinical at the moment. The second preamble is that I chose for myself this topic, but I took it as a challenge because radiomics, of course, has its roots in radiology, in diagnostic imaging, but radiomics requires competencies in computer science, informatics, engineering, and it's definitely a challenging topic. Because many of these competencies are outside the perimeter of radiologists and outside my competencies. But I think that this is something we must be very aware of because radiomics could influence our near future. So what are we going to talk about? Radiomics is essentially a set of methods that leverage diagnostic images in order to extract a large number of quantitative features that are analyzed mathematically in order to take out of this amount of data unique patterns that help us to define the digital fingerprint of a disease. Be it a neoplastic disease, this is more frequent, but even non-neoplastic diseases. So in principle, all this work is similar to what happens for many of the other omics that emerged in the literature in recent years. And in fact, radiomics from many aspects may be considered a complement to the other omics. So essentially, we are talking about another way of the big data analysis. And data analysis collects a number of information that are classified in 4 different classes in hierarchical order of complexity. It can be descriptive analytics, which means the identification of attributes, features, and measures that collectively represent the object of interest, the disease in this case. Or it can be diagnostic analytics, which is a step further. It's an attempt to explain the meaning of findings. This is what we call in our daily routine radiopathologic correlates. And in fact, interestingly, descriptive and diagnostic analytics is something we do in our daily routine. On your left side, you have an oral cavity and oropharyngeal tumor, and you see how linear measurements, volumetric measurements, assessment of enhancement, necrosis, shape of the lesion collectively describe the object and define its nature and its spatial position. On the right side, you see how the MRI pattern of an inverted papilloma to some extent is the imaging representation of the histological architecture. So it's a sort of a diagnostic analytics. Of course, what Radiomix can do in terms of descriptive and diagnostic analytics is much more complex and sophisticated than what can be done by the human eye in the daily routine. The third and fourth levels in data analysis are predictive and prescriptive analytics, which means that we may use data in order to predict the characteristic of future events and, as a consequence, to prescribe actions based on such forecasting. And this is definitely something that is out of the daily practice of a radiologist in the vast majority of cases. So this is really where Radiomix seems to be promising and a game changer for radiology in the near coming future. So overall, as I said, this is very interesting, but still quite far from being clinical routine because although interesting, the technique, this kind of analysis has not reached such a level of robustness to be translated into clinical practice. Why this? There are a number of reasons. So to try to understand these reasons, probably the first essential step is to try to understand what is Radiomix and what is the pipeline behind the path that leads from acquiring imaging to obtain big data about these images. So the workflow may be divided in 5 steps. The first step, of course, the assumption is that the information are contained in images. So the first step is image acquisition. And if we want to obtain robust data, we must be aware of the physical characteristics of the modality that we use to acquire such data. So we are talking about inherent physical characteristics of CT scanning, MRI scanning, or PET-CT scanning, although there are also radiomic works on ultrasound and even on conventional X-rays. There are then some variables that are related to the object, its geometry, artifacts, contrast agent, motion, and so on. And there are some protocol configuration, of course, the scanning parameters, but also the reconstruction and the filters that are applied to the image that we routinely acquire. The second step is represented by image segmentation that is more or less traced in this olfactory neuroblastoma on the right side. This can be done manually, but we must be aware that in this case, it is going to be a very time-consuming activity, even more so if we want to acquire data not only on a 2D image, but if we want to acquire a volume of interest. So there is possibility to have semi-automated segmentation based on region growing algorithms. This is something that we have for other applications in our workstations daily. But there are also automated segmentation methods and probably what is coming next and what will be the future is deep learning algorithms that are able to segment images, therefore reducing the time needed to obtain the information. The third step is image processing. Image processing may be simplified in the 3 steps that are represented in this picture taken from the literature. The first one is interpolation. That means transforming the volume acquired into an isotopic volume in order, as a first step, to try to normalize different images acquired, and as a second step, in order to avoid bias for those features that are influenced by direction. Of course, if we have isotopic voxels, this kind of bias is minimized. The second step is resegmentation. That means getting rid of the outliers, all the pixels with very high or very low signal intensities or signal densities. And the third step is discretization. That means reassigning the intensities of all voxels to narrower ranges in order to avoid the dispersion, the sparsity of data. All this work is done by softwares, and there are many different softwares that may do this. The fourth step is feature extraction. The number of features that may be extracted from images is vast. Here you have one of the most common classification of the different features that may be obtained with radiomic analysis. And this scheme of the literature just represents the first order features and texture related features, just to give you an idea of the wide amount of data that we can get from images. The fifth and final step is feature analysis. Again, this is done by softwares which try to identify the relationships that may explain imaging data and develop, consequently, predictive biomarkers. This is done by machine and deep learning algorithms, and may be done also with statistical analysis. So there are many steps. One should be aware that each of these steps may introduce some variability in the data we obtain. So if we want to read critically all the papers that are exploding on scientific literature about radiomics, we must know all these potential pitfalls. And the same, of course, if we want to try to get into the game of radiomics. So the first step, image acquisition. There are many different techniques that may be used. There are inherent differences between vendors, even if we consider the same kind of equipment. The protocols may significantly vary between institutions, even if we consider that same specific CT or MRI scanner. And sometimes protocols may vary significantly even between physicians, because each of us try to put its own signature on the studies done daily. So all these considerations come to the conclusion that harmonization of protocols is essential in order to have reproducible and robust radiomic features. And this is very difficult to obtain if you project a multi-center study. Sometimes it's even difficult if you design a study at your own institution. Retest analysis may be beneficial in order to find out what is the inherent variability of the features you are extracting. And there are also some post-reconstruction tools, like the combat normalization algorithm, but there is more than one, that work in terms of normalizing the images coming even from different equipments produced by different vendors. Image segmentation introduces additional variability. There are two problems. We already discussed about the post-processing time, but image segmentation has an effect also on the reproducibility of the results. And so I want to discuss with you the results of this paper, which was done in the University of Milan recently. These authors worked on PET-CT images, and they compared the results of segmentation done by two different human operators, a semi-automated algorithm and four different automated algorithms in head and neck tumors and in pancreas tumors. And you see very well that there doesn't seem to be a statistically significant difference between the work of the two manual operators and semi-automated and one of the automated algorithms in head and neck tumors. Whereas there is a significant difference between the work of the two different operators in pancreatic tumors. What is the effect of this? There are two effects. The first one, we can be happy because apparently semi-automated algorithms work well, and this is an improvement for us in the future. It will help us to do the job much faster. But the second point we must consider is that this variability, which is less important in head and neck tumors, still results in 19% of radiomic features that have inter-observer correlation coefficient that is less than 80%. And this figure increases up to 47% of pancreatic radiomic features due to this higher variability in segmentation. So this is why most of the literature seems to orient toward the fact that in the future, deep learning will be the most effective way to segment images. But of course, this has a drawback. If deep learning is going to do this, probably our role as radiologists will be diminished. The third point and fourth point, image processing and feature extraction. I already alluded to the fact that these two steps are done by softwares. There are many different softwares. Some are commercial products, some are freewares, and there is, of course, great variability between the results that we may obtain applying different softwares. For this reason, I find very interesting the Image Biomarker Standardization Initiative, which is an international initiative that aims at obtaining a mathematical definition of features so that they are standardized internationally. They aim at obtaining explicit definition of any new feature coming into the arena, and they provide help in terms of checking the compliance of your entire pipeline with the standardization initiative itself. So all these steps aim at obtaining standardized results that may reproduce widely and not only at your own institution. And so we come to the other pitfalls coming from feature analysis. There are two main problems, the problem of overfitting and the problem of domain bias. Overfitting means that the patterns you identify in your series applying to your training set, but cannot be generalized, which means that cannot be translated to another series obtained elsewhere in your country or elsewhere in the world. This occurs more frequently when you select too many features, and so there is some sort of noise in the radiomic analysis that influences your results. And the second problem is with domain bias, which is a sort of bias that comes from the selection of your data set. And there is an interesting example, and I think clear example I found in the literature. If you train a data set on liver cirrhosis, and if you feed this data set with CT scans of cirrhotic livers and MRI scans of normal livers, the system will probably understand that any CT scan is cirrhosis, any MRI scan is normal liver. So it will be trained on the modality rather than on the disease. So one should be very careful when designing the experimental set. The number of features selected for the radiomic analysis should be proportional to the number of the series you are working on. And is absolutely essential to have a retest of the data that you obtained. The best solution would be to have to test your results on an external set. And there are also some freely available external sets in the internet that one can use to test his own results. But most of the literature works are retested in the same institution by splitting the series into a training, validation, and test subgroups. And this is, of course, a lower level of validation. So the data can be analyzed statistically or with artificial intelligence. And so there is a great intertwining between radiomics and artificial intelligence. Artificial intelligence may work in terms of machine learning, and this is generally a supervised learning, which means that the system is fed with labeled data. So the system is fed with both images and the diagnosis and learns to correlate diagnosis and imaging features. Or this can be done with deep learning algorithms with unsupervised training, which means that the system is fed with unlabeled data and learns to find correlations that define a disease and discriminate disease from normal. And this is more or less schematically what happens. There is an input, there is a number of layers of artificial neurons that are connected through weighted connections, and the data travel from one level to the other to reach the output, which is basically the solution and the work that is done by the neural network for you. How all this applies to head and neck. There is an explosion of literature papers on radiomics and head and neck, and this slide summarizes all the issues that have been studied with radiomics, from histological grade down to the categorization of molecular subtypes. There is a number of papers, so I think that the best way to evaluate and critically read these papers is to pass them through a filter that is made of the clinical interest of the topic that has been studied, the presence of an external validation, and as a consequence of this, the possibility to have a clinical translation for the data that have been found in a research environment. So I will try to discuss some of the evidences of the literature. For example, there is this work published in 2019 on the differentiation of the histological grade of squamous cell carcinoma. And in this work, well-differentiated squamous cell carcinoma was differentiated from moderately and poorly differentiated carcinoma on a training set made of 137 patients, with a testing set of 69 patients, with the extraction of 670 CT features. And as you see very well, the model obtained by Radiomix works much better than the clinical model in this discrimination. And if you mix clinical and Radiomix data, the two together work even better than the Radiomix signature alone. So the first point here is I'm not entirely sure this kind of information that is obtained laboriously with Radiomix is really essential, is really a game changer in the clinical scenario. The second point, of course, there is a great difference between clinical and Radiomix data. What would be interesting would be to correlate the Radiomix signature with a descriptive signature obtained from an experienced radiologist. Tumor characterization. There is a number of works in the literature on salivary gland tumor characterization with Radiomix. All of these works obtain good results in terms of accuracy and area under the ROC curve. The discrimination is in most cases between warting tumor and pleomorphic adenoma, warting tumor versus benign or malignant tumor, or benign versus malignant tumor. So of course you cannot obtain a differentiation of the multiple different salivary gland tumors. It's promising, it's interesting, but again, we have a much easier approach, which is the combination of dynamic contrast enhancement and DWI, which works very well when you have to discriminate a warting tumor from a pleomorphic or malignant tumor. So I'm not entirely sure that the great effort that is behind this work is really worthwhile in the clinical practice. Nodal staging, this is really interesting because nodal staging has always been a problem, and already Steve showed that even in WI, you can have some serious problems in identifying nodal metastases. So here this is an interesting work on 260 patients and 653 lymph nodes. And you see very well that deep learning algorithm, but also benchmark logistic, clearly differentiated quite well nodal metastasis from normal lymph nodes, but also predicted quite efficiently extranodal extension. This is very interesting in principle. The only thing that leaves me with some doubt is the number of lymph nodes. The range was 1 to 5 lymph nodes per patient, which leaves me the impression that probably only the really evident, morphologically evident lymph nodes were selected. HPV status. This application has been studied in different works in the literature. I'm not aware of any Radiomix signature available. We also tried to test this hypothesis in a work that we published in 2019 in my institution. Interestingly, we found out that ADC values were quite good in differentiated HPV positive from HPV negative, whereas the radiomic features that we obtained from a post-contrast sequence with fat suppression showed a trend toward discrimination, but with no statistical significance. And the last point, local tumor control. This is really another point that clinical in the daily life is essential. So I want to discuss the results of this paper from MD Anderson Cancer Center. They selected nearly 500 oropharyngeal cancer patients and they extracted radiomic features, and you see that 134 starting radiomic features were narrowed to 2 features in order to obtain a decision tree modeling with quite interesting results in terms of the definition and the prediction of local tumor control. So this is interesting clinically, and it's even more interesting, in my opinion, from a logistic point of view, because in this center, many patients are treated with radiation therapy with an MRI-guided linear accelerator. What is interesting is that there are almost 50 such machines all over the world, and all these 50 machines are connected by a network, a scientific network. So this seems to offer the grounds for more easily reproducible studies, because in this network, everyone is using the same machine, the same sequences, which are locked by the producer, and the same protocols. So this really diminishes all the variabilities that I discussed in the first part of the presentation. So coming to a conclusion, I think that I stressed the concept that standardization is essential and is at the moment, in my opinion, an issue in radiomics. The calibration of radiomic features across vendors and protocols and sites should be obtained in order to have results that are comparable and then clinically translatable. Possibly, the future is deep learning. There are different levels of deep learning algorithms that made the task of detecting the lesion, do the segmentation of the lesion, and then extract all the features. And of course, the future of radiomics is the integration with other omics. In particular, I think what will be triggering will be the integration with pathomics and videomics. There are other image-based techniques. So the comparison with these other omics might make the interpretation and the explanation of the results more easy. So thank you very much for your attention. And I guess that if any question, yeah, already I think we have.
I think, Davide, we don't have any specific questions, and I think we're
okay.
run out of time. I think probably myself running over. But thank you for such a difficult subject to address, and you managed it quite clearly, which is very impressive. I suppose it's something that it's going to continue to evolve, and something that we're all going to have to know a little bit more about in the future. So yeah, thank you for that.
Okay.
So on behalf of myself and Davide, thank you very much for listening, and I hope you found those two presentations useful.
Thank you very much. Goodbye.